My name is Dr. Fiona Duffy. I'm a consultant clinical psychologist in NHS Lothian CAMHS, and I'm here today to talk in relation to the question around support for families and carers. So this was specifically key question 19, where we looked at what interventions are effective in supporting parents, siblings and carers of people with eating disorders. And we were really interested in any intervention specifically looking at outcomes in relation to reduction in anxiety or distress for parents and carers, or improvement in quality of life, but also any improvements in sustained outcomes for patients with eating disorders as well. In terms of the rationale for this question, we know that eating disorders impact the whole family and can cause significant distress. Indeed, parents and carers have been shown to experience high levels of emotion, caregiver burden, distress and difficulties coping. But we also know that inadvertently this huge significant psychological impact on carers can lead to, at times, the presence of quite ineffective strategies for supporting an individual with an eating disorder. So this can inadvertently exacerbate patients' distress and also then in turn eating disorder symptoms. So via our search in terms of all of the identified randomised control trials that we found were based on the cognitive interpersonal maintenance model of eating disorders and that associated materials to that model, which were mainly based around the kind of new Maudsley method. So we found that there was a number of RCTs which supported the delivery of some of these interventions in a range of different formats, including online delivery via Overcoming Anorexia Online, which was a web-based intervention with support from clinicians. Also self-help material, which is known as ECHO, so that's Expert Carers Helping Others, which comes in both self-help material of a book and associated DVDs, but can also be accompanied by support via a clinician or an expert carer. And then finally also we found some RCTs which explored the use of workshops, and this was specifically our collaborative carer workshops, again based on the new Maudsley method. So in terms of some of the outcomes associated with these different formats of intervention, we found that when we were looking at waiting list or less intensive controls, our outcomes looked good. So Overcoming Anorexia Online, which the web-based intervention with limited clinician supportive guidance, demonstrated greater impact on carer distress than access to ad hoc telephone support with BEAT, the National Eating Disorder Charity. And also a 2-session collaborative carer skills workshop led to larger improvements in carer burden than waiting list controls. However, when we begin to look at more active controls or treatment as usual comparisons, the evidence is beginning to get slightly more mixed. So we have a pilot RCT comparing the 6-session collaborative carer workshops to quite a robust psychoeducation group, where we found no significant difference on any carer outcomes. By far the greatest body of evidence we found was for ECHO, so the Expert Carers Helping Others approach. And we found a pilot RCT comparing ECHO and treatment as usual to treatment as usual by itself, which found that ECHO led to moderate increases in carer skills and a reduction in counterproductive caring behaviours at 12 months in comparison to treatment as usual alone. And similarly, another RCT exploring treatment as usual and ECHO, which included telephone coaching to treatment as usual by itself, found no significant difference in carer distress, but significant differences at 6 months in caregiver burden and expressed emotion in favour of ECHO. But it's worthwhile noting that the differences between these interventions didn't extend to the 12 or the 24-month follow-up period. We were also kind of thinking about some of the clinical considerations as part of reviewing some of these RCTs. So by far ECHO had the greatest body of evidence, but even within ECHO the engagement was very variable within trials from 21% to 75%. We also found that 2 RCTs found no additional benefit for telephone coaching in addition to ECHO self-help materials for improving carer outcomes, which was quite a surprising finding for us, because obviously that's slightly at odds with lots of the other mental health research around guided self-help. And finally, trials included a mixed sample of carers of adults and adolescents, but none with younger children, so the under 12s. Therefore, we felt that clinical judgment should be used in the applicability of this model within a CAMHS setting and should be used on an individual basis, both for the under 12 populations, but also that there may be some conflict with some of the advice based on some of these interventions and that provided within family-based treatment. So finally, in terms of in relation to this question, our specific recommendations were that former carer support should be offered to all carers, and this could draw material from ECHO self-help or collaborative carer workshops. And finally, that family and carer support can be provided without breaching confidentiality. Thank you very much.